Welcome to the deep dive. We take your sources, all that research and those notes you've gathered, and really boil it down to what's essential.
Getting straight to the point.
Exactly. And today, we're tackling something critical, stroke management. You've sent over a great mix of material articles, guidelines.
Yeah, covering quite a range.
Right. Acute ischemic stroke, the clot busters, then the bleeding strokes, ICH and SAH, and that really complex area of reversing blood thinners during a brain bleed.
Which is super important and often really challenging in practice.
Absolutely. So our goal here is to unpack all of that for you. Find the key takeaways, maybe some surprising details, and give you that actionable knowledge fast. It's your specific deep dive. Okay, let's unpack this.
And I think right off the bat, it's clear from your sources how crucial understanding the nuances is. Because the approach really shifts depending on, well, what kind of stroke we're dealing with.
Yeah, that's the perfect starting point. Stroke isn't monolithic, is it? The sources make that clear immediately. Different types, different causes.
Precisely. You've got ischemic stroke, that's the blocked pipe analogy, right? A vessel blocked. Versus hemorrhagic stroke, that's a leak, bleeding in the brain. And your sources focus heavily on two types of bleeds: intracerebral hemorrhage, or ICH, bleeding right into the brain tissue.
Okay.
And subarachnoid hemorrhage, SAH, which is bleeding in that space around the brain, often from an aneurysm.
And how we handle them, especially things like blood pressure and reversing meds, is totally different.
Totally different. Worlds apart sometimes.
So let's kick off with acute ischemic stroke, AIS. The blockage.
Yeah.
Goal number one is often getting that vessel open again, yeah.
Right, restoring blood flow. And that brings us straight to thrombolytics. Alteplase is the main one mentioned.
Alteplase or RTPA, the clot buster.
Exactly. It's designed to dissolve that clot. Your sources lay out the standard dose, 0.9 milligrams per kilogram of body weight.
Okay.
But capped at 90 milligrams total. And it's given in a specific way, right?
Yeah. 10% is a quick push, a bolus.
And the rest, the other 90%, infused over an hour.
And the clock is ticking, big time. The sources mentioned the NINDS trial that really set the stage for using alteplase within 3 hours.
That was the landmark study, yeah. Established that initial window, but then the question became, well, can we push that window out a bit?
Which leads to trials like ECASS-III, looking at that 3 to 4.5 hour time frame.
Exactly. Testing alteplase in that slightly later period after symptoms start.
Here's where it gets really interesting, because ECASS-III, on the face of it, seemed positive. What did they actually find?
Well, they did show a significant improvement. They used the modified Rankin scale at 90 days. 0-1 means minimal or no disability.
Right. A good outcome.
And in the alteplase group, 52.4% hit that target, compared to only 45.2% in the placebo group. So statistically, more people had a better functional outcome.
Okay, so better outcomes sound good, but there's always a but with powerful drugs, isn't there? What was the trade-off?
The trade-off was bleeding. Specifically, symptomatic intracranial hemorrhage, bleeding in the brain causing problems.
Not good.
No. It happened in 2.4% of the alteplase patients in ECASS-III versus just 0.2% with placebo. So a definite increased risk of a serious bleed.
Wow, that's quite a jump. But did it affect overall survival?
Interestingly, no. The overall death rate at 90 days was pretty similar, 7.7% with alteplase, 8.4% with placebo. Not a significant difference.
Huh. So better chance of good function, higher chance of a serious bleed, but similar overall survival. Makes the decision complex, right?
Very. And this is where, some of the debate comes in, which one of your sources, LITFL, touches on.
Ah, the controversy.
Yeah. Critics point to potential issues with even the positive trials like NINDS and ECASS-III, things like maybe subtle differences in the patient groups at the start or potential methodological weaknesses, industry influences sometimes mentioned too.
So maybe not quite as straightforward as the headline results suggest.
It's arguably not. And your sources also mentioned that actually many other alteplase studies didn't show a clear overall benefit or harm. Plus, there are real-world challenges, like how hard it is sometimes to be sure it's a stroke and not a mimic that happens in maybe 10, even 30% of cases. Giving a potent clot buster unnecessarily is risky.
Yeah, you don't want to do that.
And then there's the whole issue of how quickly patients get treated in trials versus, the average busy emergency department. Can we really replicate those super fast trial times consistently?
Add layers of complexity. And one more thing on AI, permissive hypertension, that jumped out at me.
Yeah.
Allowing high blood pressure.
Yeah, it sounds backward, doesn't it? But it's a key difference compared to bleeding strokes. In ischemic stroke, if the patient isn't getting thrombolysis or thrombectomy, or if their BP is okay for those treatments, we often let the blood pressure run higher than normal. The idea is that higher pressure might help push blood through collateral vessels to the brain tissue that's, stunned but not dead yet around the blockage.
Ah, okay. So lowering it too much could actually hurt perfusion.
Potentially, yes. So it's a deliberate strategy in that specific context. Very different from when there's bleeding.
Right. Okay, perfect pivot then. Let's switch to bleeding intracerebral hemorrhage, ICH. Bleeding in the brain. Totally different problem now. Stop the bleed, manage the pressure.
Exactly. And blood pressure is a huge focus. Your sources dive into the ATEST-CH2 trial, which asked a really important question about how low we should go with BP in acute ICH.
What were they comparing? What were the targets?
They compared an intensive target, getting systolic blood pressure down between 110 and 139.
Wow, that's low.
Versus a standard target 140 to 179. This was in patients with fairly recent ICH, not massive bleeds, and who weren't deeply comatose. They mostly use IV nicardipine to get the pressure down, starting within 4.5 hours.
Okay, intensive versus standard. So did the super low target lead to better outcomes?
This was the big surprise. No, it didn't. The primary outcome, death or significant disability at 3 months, was almost identical between the groups, about 38% in both.
Really? No difference?
No significant difference. In fact, they stopped the trial early for futility, meaning it was clear the intensive strategy wasn't going to show a benefit.
Wow. So all that effort to drive the BP way down didn't help in this large trial.
Yeah.
So what does this all mean? Why no benefit?
Well, the researchers discussed a few possibilities. Maybe the actual difference in outcomes was smaller than the trial was powered to detect.
Okay.
Another big one was that actually a lot of patients in both groups didn't consistently stay in their target BP range for the whole 24 hours. That kind of blurs the lines.
So the real-world difficulty of maintaining tight control.
Could be part of it. They also wondered if maybe the patients enrolled were, on average, less severely affected to begin with. Many had good GCS scores, so maybe they were likely to do okay anyway, creating a sort of ceiling effect where it's hard to show added benefit from the intensive treatment.
Right, if outcomes are already pretty good with standard care.
Exactly. And they pointed out the overall standard of care at the participating hospitals was very high.
So, multiple potential reasons. But bottom line, the trial didn't support aggressive lowering. Was there any downside to it?
Yes, there was. They found significantly more kidney-related adverse events, problems with kidney function in the intensive group, 9% versus 4% in the standard group.
Okay, so potential harm without clear benefit. That's crucial. And I remember one source mentioned avoiding fluctuations in BP too. Stability matters.
That seems to be a key theme, yes. Maybe avoiding big swings is just as important or even more important than hitting one specific low number, especially given the risks highlighted by ATEST-CH2.
Makes sense. Okay, let's shift to the other bleeding stroke. Subarachnoid hemorrhage, SAH. Often the ruptured aneurysm scenario. Different challenges here, right? Like rebleeding, vasospasm.
Beautifully distinct challenges. Your SAH source lays out the goals clearly, stop the bleeding from getting worse, prevent it from starting again, rebleeding is often catastrophic, prevent delayed brain injury or ischemia, manage intracranial pressure if it goes up, get ready to fix the source of the bleed, optimize vitals, prevent things like aspiration, lots to juggle.
How's BP handled here? Different again.
Different again. The target mentioned is generally systolic, less than 160, or a mean arterial pressure, MAP, below 110.
Okay, higher than the intensive ICH target.
Right. And they emphasize treating pain and nausea first, as that often brings BP down. If meds are needed, labetalol or hydrolazine are suggested. Big cautions. Avoid nitrates, as they can raise ICP, and crucially, avoid hypotension. Aim for a MAP above 80. Sometimes vasopressors are needed early.
Got it. Avoid lows, keep it below 160 systolic or 110 MAP, and managing ICP.
Key interventions there. Elevating the head of the bed is standard. For medical management, hyperosmolar therapy is used. The source prefers hypertonic saline over mannitol if available.
Right.
And brief, cautious hyperventilation might be used as a temporary measure, but very carefully.
You mentioned delayed problems. Vasospasm sounds particularly nasty.
It is. It's a narrowing of the blood vessels that typically happens days after the initial bleed, usually after 72 hours, peaking around day 7. It can cause strokes and devastating outcomes.
And is there anything specific to prevent that?
Yes. Nimodipine. Your sources strongly recommend it.
Nimodipine, how's it used?
It's given orally, 60 milligrams every 4 hours, started within 48 hours of the bleed. This is standard practice backed by guidelines.
Oral, not IV.
Definitely not IV. The source has a clear warning. The IV form has been linked to bad outcomes, so oral or NG tube only.
Good distinction. And this cerebral salt wasting thing sounds complex. Brain affecting salt levels.
It is, yeah. Basically, the blood irritating the brain can mess with hormones and cause the kidneys to dump too much salt. Water follows the salt, so the patient gets dehydrated and hypotensive.
And that's bad because
Because being dehydrated and having low blood pressure and SAH massively increases the risk of that delayed vasospasm and ischemia we just talked about. It's a dangerous cycle.
So how do you stop that?
Vigilance. You have to watch urine output like a hawk, assess fluid status constantly, check sodium levels. The goal is meticulous fluid and salt replacement to keep them euvolemic, normal fluid balance, and unitremic, normal sodium. Match intake and output.
Makes sense. What about seizures? Do all SAH patients get preventative meds?
No, not automatically. Your sources say routine prophylaxis isn't needed for everyone. It's reserved for patients with specific risk factors.
Like what?
Things like a ruptured middle cerebral artery aneurysm, associated ICH, a really bad bleed, hydrocephalus, signs of brain injury, if they've already had a seizure, if they're intubated or have a low GCS or ongoing bleeding.
Okay, so targeted prophylaxis, preferred drug.
Levetiracetam is preferred. Phenytoin is an alternative.
Got it. And their general critical care goals too, right? Just
Yeah.
keeping things stable.
Absolutely. Maintaining normality is key for the injured brain. So normothermia, normal temp, normal carbia, normal CO2, euvolemia, euglycemia, normal sugar, normoxia, good oxygen, unitremia, normotension, basically keeping everything in the normal range and avoiding big swings.
And I saw a note about TXA, tranexamic acid. Not recommended here.
For spontaneous, non-traumatic SAH, yes, the sources advise against TXA.
Okay. And ultimately, you have to fix the underlying problem, the aneurysm usually.
That's the definitive treatment, yeah. Endovascular coiling or surgical clipping to secure the aneurysm and prevent rebleeding is essential.
Okay. So we've covered ischemic, ICH, SAH. Very different approaches. But the elephant in the room often is that the patient was already on blood thinners. That throws a huge wrench in the works when they have a brain bleed.
A massive wrench. Having an intracranial bleed while on antithrombotics is known to increase the risk of the hematoma expanding, which leads to worse outcomes, including death. So reversing those agents quickly becomes a top priority.
And that's where that detailed guideline source comes in. What's its main aim?
It's designed to give evidence-based recommendations on how to reverse specific antithrombotic drugs in patients with any kind of intracranial hemorrhage, ICH, SAH, subdural, epidural, traumatic bleeds. It tries to bring some structure to a complex area. It does mention its literature review cutoff was late 2015, so that's a point to keep in mind.
Right. And it grades the recommendations. Strong, conditional.
Yeah, using the grade system. Strong recommendations mean they're confident the benefits outweigh risks for most people. Conditional means the balance is less clear, more patient-specific factors involved. And there are good practice statements, too, for fundamental things.
Okay, let's run through some common ones based on that guideline. Patient on warfarin bleeds in the head. What's the plan?
First, stop the warfarin, obviously. Then, the guideline strongly recommends IV vitamin K, maybe 10 milligrams to start. That helps rebuild clotting factors long-term.
But that takes time, right? What about immediate reversal?
For immediate reversal, if the INR is high, say 1.4 or more, it strongly recommends using prothrombin complex concentrates, PCCs, specifically 4-factor PCCs, if available.
Over FFP, fresh frozen plasma.
Yes, strongly preferred over FFP, because PCCs are faster, more concentrated, less volume. The dose depends on weight and INR.
Clear preference there. What about the newer guys, the DOACs? Like factor XA inhibitors, apixaban, rivaroxaban?
Still stop the drug. Activated charcoal is suggested if it was taken very recently, like within 2 hours, and aspiration risk is low. For reversal itself, the guideline suggests using 4-factor PCC or activated PCC, APCC, often dosed around 50 units per kilo.
Okay, PCCs again.
Yeah, especially if the bleed is within a few drug half-lives or if the patient has liver failure. The guideline suggests PCK-PCC over recombinant factor A, partly due to potentially lower thrombotic risk with PCCs.
And the other main class of DOACs, direct thrombin inhibitors, like dabigatran. That one's different, isn't it? Has a specific antidote.
Exactly. For dabigatran, the guideline strongly recommends using its specific reversal agent, idarucizumab Praxbind, 5 grams OFI given as 2 infusions.
So if you have idarucizumab, you use it for dabigatran bleeds.
That's the strong recommendation, especially if the timing fits or kidney function is poor. If adarucizumab isn't available, or for other DTIs without specific antidotes, then APCC, or 4-factor PCC, is suggested, again, considering timing and kidney function. Hemodialysis is also an option for dabigatran with kidney problems if adarucizumab isn't available.
And what should you not use for DTIs?
The guideline strongly recommends against using RFBI or FFP for DTI-related ICH. Very specific, do not use advice there.
Wow, okay. What about old school heparin infusion?
Unfractionated heparin infusion, stop it immediately. Urgent reversal is recommended using IV protamine sulfate.
Protamine, how much?
The dose depends on how much heparin was given in the last 2-3 hours. Roughly 1 milligram protamine per 100 units of heparin with a max initial dose. You might repeat a smaller dose if the PTT stays high, but routine reversal of prophylactic heparin isn't usually needed.
And the low molecular weight heparins, LMWH, like a noxiparin?
Also protamine, but slow IV injection. Dose depends on the LMWH dose in the last 8 hours, 1 milligram protamine per 1 milligram enoxaparin, or 100 anti-DEXA units. If it was more than 8 hours ago, maybe half that dose. Reversing prophylactic doses isn't usually done. And again, FFP, PCC, APCC are recommended against for LMWH reversal. What's fascinating here is just how tailored it is. No single reversal agent works for everything. You really need to know the specific drug.
It really hammers that home. Okay, what if someone got a thrombolytic, like alteplase for ischemic stroke, then starts bleeding?
Stop the alteplase, of course. The guidelines suggest giving cryoprecipitate 10 units usually to start.
Cryoprecipitate, why?
Because thrombolytics chew up fibrinogen, a key clotting protein. Cryo is rich in fibrinogen. If cryo isn't available, antifibrinolytics like TXA or EACA are alternative. You check fibrinogen levels and give more cryo if it's low. Platelets. The guideline says it's unclear if they help here.
Okay, cryo first for post-thrombolytic bleeds. Last big category, antiplatelet drugs. Aspirin, clopidogrel, Plavix.
Stop the agent. First step. Now, here's a key distinction in the guideline. Surgery or no surgery.
Oh.
For patients with antiplatelet-related ICH who are not having surgery, the guideline suggests against giving platelet transfusion.
Really? No platelets if no surgery?
That's the suggestion. But if they are having neurosurgery and we're on aspirin or an ADP inhibitor like clopidogrel, then platelet transfusion is suggested.
Okay, that's a critical difference.
Huge difference. Ideally, test platelet function first if possible. If not, empirical transfusion might be reasonable, but definitely don't transfuse if function is normal or they're known to be resistant. And for NSAI or GPI-IBI-related bleeds, platelets are suggested against even with surgery. If you do give platelets, usually 1 apheresis unit initially.
Well, that surgical versus non-surgical split for antiplatelets is a massive takeaway.
Yeah.
And the drug specificity again. This guideline, while maybe needing an update for newer agents, provides such crucial, detailed steps.
It really does. It gives you a framework, a starting point for navigating these incredibly high-stakes reversal situations.
So we've journeyed through a lot in this deep dive. Ischemic versus hemorrhagic, the nuances of BP targets with ATH2 throwing a curveball.
Right, challenging the lower is always better idea for ICH.
The specific concerns in SEH like vasospasm and salt wasting, and then this incredibly intricate map for reversing anticoagulants and antiplatelets. It's definitely not one size fits all.
Not at all. We've seen the urgency for ischemic stroke, but also the ongoing debates about risks and benefits. For bleeding strokes, meticulous control of BP and complications is vital, but ATH2 shows standard targets can be just as good, maybe safer sometimes. And reversal is all about knowing the specific drug.
If we connect this to the bigger picture,
I think what all these sources together really underscore is the absolute need for, first, rapid and accurate diagnosis. Is it a clot or a bleed? Where's the bleed? Then applying precise evidence-guided management based on that specific situation. And having a clear plan for reversal if needed. Think about how mastering these distinct pieces, understanding why a trial like ATAS-EH2 was negative, knowing the SAHBP target is different, recalling which reversal agent goes with which drug all adds up. This raises an important question for you. How does synthesizing all these specific, sometimes conflicting pieces of evidence change your overall approach, your mental model, when you encounter that patient with an acute neurological deficit? How does it shape your confidence in navigating these complex critical care decisions?
that's a really powerful question to reflect on. Thanks for walking us through this complex landscape. And thank you, our listener, for joining this deep dive. We hope this helps you continue your own exploration.